Understanding Genetic Kidney Disease and its Impact on the Black Community. Insights into APOL-1 gene. This session will get your mind going. We want to give a warm welcome to Dr. Stacy A. Johnson. She is an Associate Medical Director in Clinical Development at Vertex Pharmaceuticals in Boston, Massachusetts. Prior to joining Vertex Pharmaceuticals, Dr. Johnson spent her career helping to train medical students, residents, and nephrology fellows. She served as the medical director for the acute dialysis unit and plasmapheresis service at Regional 1 Hospital in Memphis. So please welcome Dr. Stacy A. Johnson to the stage.
I want to say thank you to Black Health Matters for the invitation to speak to you this afternoon. My name is Stacy Johnson. I'm a nephrologist by training, and I spent about 10 years taking care of people with kidney disease. And currently I work for Vertex Pharmaceuticals, which is a biotech and pharmaceutical company based in Boston. Vertex has worked for many years on diseases that affect people's lives, particularly those that have a genetic cause like cystic fibrosis, sickle cell disease, and now APOL-1 mediated kidney disease. So today we're going to talk a little bit about kidney function, kidney disease. We'll talk about the burden that kidney disease exerts on the society, but particularly also among the Black community. And then I'm going to introduce a topic about a gene called APOL-1 or apolipoprotein L1 that's involved in kidney disease and has become associated with more severe forms of chronic kidney disease, particularly in African Americans. And then we'll touch on some of the how we diagnose it and what, because it involves something called genetic testing and what that means, and then share at the end some resources that for those of you who want additional information you can go to. So the kidneys are these two bean-shaped organs. They sit sort of towards the back of the body under the rib cage. And the kidneys play a really, really important role in maintaining balance. They help keep the fluid levels in your body in balance, in check. They help maintain the right levels of very important electrolytes like sodium and potassium and calcium. And the kidneys also do things like getting rid of waste products, right? As you're going through your daily life, you live, you eat, you breathe, you generate waste products, and the kidneys help clear that waste. And the main functional unit of the kidney is this little thing here called, I don't know if you could see my pointer, but there's a little, there we go. It's kind of low. So this thing here, this nephron, your kidneys are actually made up of like about 1 million of these, right? And that's kind of how the kidneys work. And so I want you to pay attention to this sort of tennis racket shaped structure up here that's called the glomerulus, because when that gets damaged, you can develop pretty significant kidney disease. All these tubules here are really important because they help the glomerulus, or that sophisticated sieve. It works to get rid of waste, but hold on to important things like protein. And then as the urine goes through all those tubules, it gets refined. Some things get added, some things get taken away, and then the ultimate end product is urine. The important thing to think about is that urine is not just water. Urine actually contains waste products, it contains electrolytes, it may contain some sugar if you're a diabetic person, but it shouldn't really contain protein. Now, what happens when kidneys don't function properly? So for whatever reason, maybe something else is going on in the body and the kidneys are getting damaged. When that glomerulus, that sieve gets damaged, it's no longer able to hold on to the good stuff, the protein, and you get leaking of protein into the urine. And so that can be one of the early signs that there's damage going on in the kidneys and something is not right. The other thing is that as kidney disease progresses, you get less and less fluid being excreted from the body, less and less waste products being removed from the body. So you get buildup of fluid, buildup of waste, and then also, unfortunately, you start losing protein in the urine. And this is when you see those things together, it's called, especially if it's been going on for months and sometimes years, it's called chronic kidney disease. The CDC estimates that about 37 million people in the United States have chronic kidney disease, but because the symptoms of CKD are silent until the advanced or late stages, most people, 9 out of 10 US adults, actually don't know that they have kidney disease. And kidney disease comes with a cost. So this slide shows you the cost in healthcare spending. You know, $124 billion a year it's spent taking care of or spent on the treatment and management of chronic kidney disease. But kidney disease also has a human cost, right? The time spent in the doctor's offices, the time spent, if your kidney disease progresses and you have to end up taking dialysis, the time spent in the dialysis unit or on dialysis. And then kidney disease has a human cost because it can lead to what I like to call a premature death, right? Because people with kidney disease, especially when it progresses to end stage, will often die at younger ages than they would have if they didn't have kidney disease. This graph shows you the new cases of kidney failure in the United States from 2000 to 2019. And it's divided or organized by ethnicity and racial and ethnic differences based on the numbers per year. And you see that blue line right there at the top, right? So, and if I took this, and if I showed you this graph for the 1990s, it'll look pretty much the same. If I went out past 2019 and showed you the one for 2023, it'll look exactly the same. African Americans account for 13% of the US population, but they represent 35% of people with kidney failure who are on dialysis or needing a kidney transplant. That is a very disproportionately high burden of kidney disease. And there are lots of reasons that this could account for this. Some of it is, as the previous speaker talked about, those socioeconomic conditions, social determinants of health in terms of access to specialty care, early referral to nephrology, to a kidney specialist like myself. But in 2010, what scientists actually showed is that there are changes that happened thousands of years ago in a gene called apolipoprotein L1, and we'll call it APOL-1 for short, that actually lead to higher rates of kidney disease in African Americans. So these variants, so typically, because this is a genetic disease, think of your genes as the instructions for everything, kind of how your body works, right? Your genes not only control, our genes not only control what our eye color is going to be, what our hair color is going to be, but the genes also control sort of how our body works. And what scientists showed in 2010 is that this gene, APOL-1, has two variants, two changes that happened 3,000, 5,000, 10,000 years ago that actually now we're seeing as being one of the primary causes of higher rates of chronic kidney disease in the Black community. Genes, because this is a genetic thing, this is a genetic condition, you can actually get one copy or one variant from your mother, biological mother, one variant from your biological father, and then you may end up carrying that genetic risk for kidney disease. So what is APOL-1? APOL-1, these variants that we call G1 and G2, actually, as I said, emerged thousands of years ago in sub-Saharan Africa, specifically Western and Central Africa. And it turns out that having one of these variants, or two, is actually protective. It protects you against infection from a parasite that causes sleeping sickness. So people in that part of the world, if they have one of the variants, so maybe they have a G1 or a G2, they can actually be protected against sleeping sickness. Now, if you have two of the variants, if you have one from your mother, one from your father, you get that protection, but you also have this increased risk of kidney disease. And the variants, as I said, they're called G1 and G2. The original sort of parent gene is called, the original gene that before the variants is called G0. And that's important because when you, if we talk a little bit later about genetic testing, that's what genetic testing looks for, is those variants. So, okay, you're like, well, I live in DC, this is something, we don't have sleeping sickness, this is in sub-Saharan Africa. But we know the history of the world is not like that, right? So, so because of the transatlantic slave trade, because of voluntary migration, we can now find people who have ancestors from sub-Saharan Africa all over the world. But then that means that if you look on almost every continent, you can find people carrying these variants. So we have in the United States, Canada, Latin America, for example, in countries like Brazil, in the Caribbean, as well as in Europe, right? So in addition to sub-Saharan Africa, these variants, these APOL-1 variants, can now be found in people living all over the world. Now, just because you have 2 copies of those variants doesn't mean you're going to develop kidney disease. What we know now is that there's also got to be something called, what we call like a second hit. So maybe it's an infection, like COVID-19, or maybe it's inflammation, like an autoimmune disease, such as lupus. And so what we find now is that people with these variants can have kidney disease that looks a little different depending on how depending on what caused the kidney disease. So for people with lupus, they may have something called lupus nephritis, which is a kidney disease that's associated with lupus. People may develop something called focal segmental glomerulosclerosis, or FSGS, which is sometimes usually you see massive amounts of loss of protein in the urine. People have swelling and retention of fluid. And then sometimes for some people with APOL-1 kidney disease, it's the form of hypertension or hypertension-associated kidney disease. And as I said, just because you have those 2 variants doesn't mean you will develop kidney disease. But if you develop kidney disease, it is usually much more likely that someone with APOL-1 mediated kidney disease will progress to kidney failure and needing to be put on dialysis or have a kidney transplant. The symptoms of APOL-1 mediated kidney disease are actually quite subtle early on. People may have some fatigue, which, most people have fatigue, and so you may not associate that with chronic kidney disease. People may see swelling in their feet and legs, and I talked about the kidneys being the way that you help get rid of excess fluid. If you can't get rid of excess fluid, it's got to go somewhere, and it goes in the legs, it goes in the feet. So you might see you're gaining weight because you're retaining fluid. And then if the protein in the urine is a lot, if you have a lot of protein in the urine, you may actually also notice dark or foamy urine when you go to the bathroom. The key thing here is that in many cases, this condition progresses silently, and symptoms will only start to show up when it's quite advanced. So how do you diagnose APOL-1 mediated kidney disease, or we'll call it AMKD for short? Well, I told you about the protein in the urine, so you got to have a urine test. And with a urine test, we can detect protein, and then we can even measure how much protein there is. And then you have a blood test that tells you what your kidney function is. I think most of us in this room have been to the doctor, we get labs, and you see that on the lab report, there's something called the creatinine. And creatinine is a waste product. It is not toxic, it doesn't hurt you in any way, it's just a waste product. And the only way that creatinine can leave the body is actually through the work of the kidneys. So when the kidneys are not working well, creatinine levels will build up. And we use that to help calculate something called your estimated glomerular filtration rate, or eGFR. And that's just a measure of how well your kidneys are working or not working. The other key piece in determining whether someone has APOL1 mediated kidney disease is the genetic testing to look for those APOL1 variants. Genetic testing is something that usually you have to talk to you can be ordered by your healthcare provider, and we'll talk more about some of the options there, but it's something that you want to discuss with your doctor. It can actually help people understand, well, why did I get kidney disease? What's the cause of my kidney disease? In some cases, people who have had genetic testing feel like they're more empowered to take control of their health. And then because this is a genetic condition, knowing whether you have these APOL1 variants can also help inform the conversation you have with your family members, right? Because there might be, there might be other people in the family who are at risk for kidney disease. And then also, if you have kidney disease and it's APOL1 mediated kidney disease, there's a lot of effort right now among scientists, among drug developers, to look for treatments for APOL1 mediated kidney disease. So knowing whether you have these variants may also put you in a position to determine if you may qualify for clinical trials if you're so inclined. As I said, genetic testing is a personal choice. It is voluntary. You talk to your healthcare provider. If you decide you want to do the genetic test, they may collect either blood or saliva. They'll send that sample to a lab. The lab will look for the APOL1 variants and then send the result back to your provider, and then they'll talk to you about what that means and what the results mean, okay? And sometimes people have a lot of concerns when they hear, okay, genetic testing, right? So how are you going to use the results? Can this be used to discriminate against me? And then is this test even covered by insurance? So we can talk about one at a time. So how are genetic testing results going to be used, right? So again, in a medical setting, when genetic testing is done, there's usually state and federal laws that sort of govern how this information is used and even who has access to this information. Many of you may have heard about the HIPAA, which is the Health Insurance Portability and Accountability Act, which is meant to protect the privacy, particularly as around health records of individuals, right? And so again, that's one of the concerns. There are some systems in place to help protect that information from and limit whoever sees it only to the people who actually need to see it, right? In 2008, the federal government passed a law called the Genetic Information Non-Discrimination Act, or GINA, that prevents and protects Americans from discrimination based on genetic testing. So it protects against discrimination with health insurance and with employers. And I would encourage any of you, if you're interested in genetic testing, to look at this, get information about this GINA, the law, but also about what the rules and laws are in your state. With respect to whether the test is covered, there are many insurance companies now that will cover some of the cost of the genetic testing, but again, it may be done on a state-by-state, maybe even a plan-by-plan basis. So this is something you would have to talk to your doctors about. If you decide to get genetic testing, there are different panels. You can have a panel where you look at all the genes, not just the APOL1 variants, or you can just do a single test for those APOL1 variants. And this slide just shows you some of the options and some of the companies out there that do testing. LabCorp, Quest Diagnostics, you may recognize as well-known laboratory services. Sometimes the medical centers associated with universities, like Howard University, will do some of the testing. You just have to talk to your provider about what your options are. If you want some more information about APOL1 mediated kidney disease, Vertex has actually partnered with NBA Hall of Famer Alonzo Mourning on the Power Forward Together campaign. And when you go to that website, because Alonzo himself is someone who has kidney disease and had a kidney transplant, and he had APOL1 mediated kidney disease. And so in this website, so he's really passionate about increasing awareness about this condition. And so at this website, you can find information about sort of what to do, information about the condition, but also about what to do and questions to ask your doctor. Here are two other additional websites that I think have very good information as well. The American Kidney Fund, as well as NEFCure International. Those websites will contain information on chronic kidney disease in general, but also on APOL-1 mediated kidney disease. Not included here, but other potential places you can go include the website for the National Kidney Foundation, or NKF, and of course the CDC always has information on chronic kidney disease and some of the features and signs and symptoms associated with it. So this is my last slide, and today we talked about kidney disease. We touched on the importance of how the kidneys and when they work well, how they keep our bodies in balance. And we also talked about what happens when they don't work well. APOL-1 mediated kidney disease is a type of kidney disease that is caused by variants in a gene called APOL-1 that happens, that is found almost exclusively in people of African ancestry and can account for some of that increased risk and increased numbers of kidney disease, chronic kidney disease in the Black community. Having two APOL-1 variants doesn't mean you will develop kidney disease, but you are at increased risk if you do have those variants. And once you do, and if you develop kidney disease, it will likely be a much more aggressive, severe form of disease that can then lead to kidney failure and dialysis. And if you have kidney disease, and then genetic testing, either for yourself or for your family members, can help you understand your risk of developing APOL-1 mediated kidney disease, but also understand if you already have CKD or chronic kidney disease, can help you understand your disease a little bit better. And with that, I will stop and take questions.
Quick question about, okay, if you have
I think
the
there's a
gene,
mic. Oh.
what's the age generally where the gene will show up if you get the chronic disease, kidney disease?
Right. So the genes are always there, right? They're there from birth. But what we know, what we know, as I said, is that sometimes there is that what we call that second hit. Maybe it's an infection, maybe it's some sort of inflammation. Unfortunately, we're still trying to understand exactly what that second hit is. But what we know from looking at studying patients who have APOL-1 mediated kidney disease is that usually the kidney disease usually comes on when people are in the prime of their life. So the most people are younger than age 50 when they develop APOL-1 mediated kidney disease. It can develop in adolescence as well, so teenagers, but a lot of times it's in that 30 to 50 kind of age range, right when you're you feel like you just kind of have things figured out and you're living your life, you can develop CKD.
Thank you.
Thank you for all of your information. It's been extremely insightful and helpful. What does it mean when you have too much protein in your urine, and is there a way that you can reduce the amount of protein in your urine? And then the other question is if you only have use of 50% of your kidney, what stage is that?
Okay.
I do have, I'm stage 3A.
Okay, so first question is, what does it mean when you have too much protein in urine? So if you remember, I showed you that the kidneys have these sort of sophisticated sieves called glomerulus. And that glomerulus is the structure in the kidney that prevents protein from getting into the kidney. So when you don't have protein in your urine, that's actually a sign of that the glomerulus is actually healthy. When you start to have protein in your urine, it means that something has happened to damage that glomerulus. And that damage if you continue to have protein in your urine, that means the damage is ongoing. And that is a sign of CKD, chronic kidney disease. If you have the protein in the urine and you have that reduced EGFR, then if you do a genetic test and you see that you have these APOL-1 variants, then you have APOL-1 mediated kidney disease. There are other types of kidney disease where people will have protein in the urine, but they don't have the APOL-1 variants. But that doesn't mean they don't have kidney disease, they just don't have AMKD. So protein in the urine is always a sign of kidney damage. That's number one. So the next thing you asked me was, so before I get into that, and so if you have protein in your urine, the next step should be to ask, what is my kidney function? Because that means there's something going on that might need further investigation. The other question you asked me was, I think you said, is there a way to limit it? Just the stage, that's right. So, okay, so in chronic kidney disease, we stage it based on that EGFR. And so if your EGFR is above 90, if you don't have any protein in your urine and everything else is fine, then your kidney function is pretty much would be considered sort of normal. But if you have protein in your urine and your EGFR is above 90, that would be considered stage 1. Between 60 and 89 for EGFR, that is stage 2. 30 to 59 is stage 3. And stage 3 is a big, big group. And so to help us understand what's happening with people in stage 3 in terms of how fast they progress, what are the things, what risk, what other conditions, comorbidities they may be at risk for, we've actually divided stage 3 into 3A, which is between 45 and 59, and 3B, which is between 30 and 44, essentially. And then if you have between 15 and 29 EGFR, that's stage 4. And then stage 5 is less than 15, and that's usually when the conversations about when to start, not if, but when to start dialysis, or when can we get you a transplant, those things happen. So the higher that number, so stage 1 is the most mild, stage 5 is severe, and we're looking at kidney failure at that point. Okay.
Dr. Johnson, thank you for your presentation. My question is about EGFR. Do you think there is a difference between EGFR in African American and Caucasian patients? And my second question is, do you have an idea what's the percentage of population with kidney disease without that gene?
Okay, so first question is there a difference between EGFR between African Americans and Caucasian patients? And the answer is no. So for many, and I'll explain why. So for many years, the way that we calculated EGFR is we use that creatinine and we put it into an equation, a formula, and we said, okay, the creatinine, here's the creatinine, this person is male and they are 45, and then the formula would say, oh, is this person black or not black? And if they were black, there was a correction that was done that actually gave someone, if you had two people with the same creatinine, the same age, the person who was black would have a higher EGFR, in essence, a better kidney function than somebody who was not black. But the thing about it is that that correction really didn't have a biological basis, right? Because what we were doing for many years was applying using a social construct like race to determine a biological factor like kidney function. So in 2020, the National Kidney Foundation and the American Society of Nephrology said, stop doing that. Stop applying this correction factor based on race and just calculate everybody's EGFR using only their creatinine, whether they're male or female, and their age. And so that's what we've been doing. And when we do that, what we find is that creatinine is the same. right? EGFR is the same for a given creatinine if you have two people of the same age, same gender, they're just whether they're white or black. So there's no difference. That's number one. The second question is, do you have instances of Caucasian people with kidney disease due to APOL-1? I'm not sure if that's exactly the question, but so this is a disease of African ancestry, right? And so we know that because this is something that that the genes are present in, were present in people who lived thousands of years ago, it is possible today to have someone who identifies as white who may have APOL1 mediated kidney disease, because we don't always know our ancestry, right? And so, yes, it's possible. The numbers are a lot smaller, much, much, much smaller, but it is possible. Okay, last question.
Yes, thank you so much for your presentation, and I may have missed this information, but I'd like to ask about it. If you look at the dialysis centers here in the Washington area, they were popping up like popcorn all over. And so my understanding is that they were full of African Americans seeking dialysis. How do we get the word out that we need to start looking at this disease very early in life so that we can prevent? I lost my aunt. She was on kidney dialysis for the last 5 years of her life, you know. And so it's sad that we're losing a lot of Black Americans because of lack of education of how to detect this disease.
So I think, so how to get the word out? So efforts like what Black Health Matters is doing here is one of the ways to get the word out. Okay, and it's one of the reasons that I'm here, because I agree. I think we just have to talk about it. We have to talk about the fact that chronic kidney disease disproportionately affects those of us in the Black community, that it's something to be taken seriously. If you get a report that says you have a little bit of protein or maybe your kidney function is a little bit down, ask for the details. Say, okay, what are we going to do? Ask the next question, what are we going to do about it? Right? And so I think, I think I heard one of the other speakers say earlier about being your own advocate. So again, asking questions when you're in the doctor's office. Sometimes doctors, we get so caught up and busy and trying to get through our schedule, we don't take the time to explain to people the significance of what the lab results are showing. So make sure and advocate for yourself so that you know. Talk to your family about it. Let people know what are the risk factors. Educate yourself about kidney disease, and then you can be that ambassador in your own community. But I know we are trying. I think for a long time, kidney disease didn't get the kind of attention that other types of conditions got, like heart disease or cancer. But we are trying, and that's changing. And so, you know, organizations like the American Kidney Fund, for example, is going to have AMKD Day at the end of April. The National Kidney Foundation. Everybody has recognized that we need to address chronic kidney disease because of that health burden. Okay. Thank you very much.